Perfect.
Yes.
Cool. So we left like a very interesting case. We haven't had anything like a good teaching case over the weekend. So I thought about going back to one of the very cool cases that we kind of left. But when I was reviewing the case, I realized that somehow it's going to introduce a very interesting subject or topic. So then I decided that probably we should do one case before that one as an introduction to that topic. So, and that's the reason why I uploaded yesterday the case number 18, which is also a very, very, very interesting case. So let's get started with that one. As always, let me post on the, so if you're part of the, how do you say this radiology rounds forum, you'll have it. But if you are not, let me just share that link with the images so you can open them right now. Chat. Okay, so that's the link. And then I will need to share my screen as well. Share screen. Oh, and again, I can't. Do you mind letting me?
Sorry, it should be fine now.
Cool. Okay, cool. Share. So I hope you can see my screen now. And I will start with, oh, I should have erased that. So we have a CT at the end. And let me go through clinical signs. I think this cat actually presented, it's an older cat, I think it's a 10-year-old animal. And he presented because it was kind of vomiting. It wasn't very clear if it was vomiting or regurgitation. And then he had an ultrasound before, and they suspected there was pancreatitis, but the animal didn't really recover or wasn't doing well. And then I think because of this idea of the possibility of regurgitation, we decided to go and take a radiographic study of the thorax. And this is what we see.
Sorry, Mariano. I can't see your screen. I'm not sure about anybody else.
No, I can't either.
Oh, because I forgot to do the last bit, which is click share.
Thanks.
There's always a last bit. So hopefully you can see them now.
That's perfect. Thanks.
Cool. And hopefully you got the link to the images to the chat, so you can open them and manipulate them and play and play with the windowing and everything. So as usual, we do always this very, let's say, boring situation, which is we just try to collect features, which things, and they can go from, I don't know if this is normal or abnormal. I don't know if this is actually an abnormal thing or it's a variation of normal, or if it's abnormal. Ideally, we want to be able to characterize and say, there is this abnormality with this size and shape and opacity and everything in this location, but we may not be able to go that far. So feel free to just try to go as far as you can, but it doesn't mean that we need to go that far. We can just say, I think you can be very, very simple and just say, I think there's more white here or there, or more black. So older cat, vomiting dash regurgitation, possible pancreatitis. We are trying to rule out regurgitation, and this is what we found.
Should we start with abnormal?
Yes.
Yeah.
Cool.
It's too white.
Perfect. So now we are not dealing with, or at least it's not obvious, as in it's not a big thing, like a pneumothorax, pneumomediastinum, subemphysema. There is something that is more opaque, so it's more fluid or more cells. I find, so the risk, I'm going to be walking, or we are going to be walking on a thin line, because I want to make one point, but it's a very complicated case. in my eyes. So that's why I'm saying, you can just go very simple, and then we'll try to walk slowly and try to define what is actually abnormal.
It's very fat, the cat.
Yes, good point. So it's an excellent point. So if we write that and then we take that as one of the features, I'm interested because it never came before in any of other discussions. How is that going to impact, the what you see, or how you interpret what you see? So how is like having a thin animal compared to having a very, very fat animal in terms of how is that going to change what we see, and how is that going to change how we interpret what we see?
Well, in the abdomen, generally, fat gives you better contrast. So if they're thin, you get poor serosal detail, and fat, you get better.
Perfect.
But we're in the chest, so I don't know how helpful that is.
So any ideas how you, it's almost, in my eyes, acts like a filter, makes sense? So if I have that in mind, there are 2 or 3 things that I will be more accepting. Let's say my degree of tolerance of some things is going to increase, because I can say these 2 or 3 findings, if they are there, may be related to the condition of the animal and may not be real. So anyone giving a go about how let's take same size of a cat and then go with a thin and a very fat cat. In which way they're going to look different, other than that thickening of the sub-Q, which is usually the big thing in the thorax?
Well, there's a lack of abdominal contrast, and normally a fat abdomen would contrast with the viscera, and that's not happening. So I would guess that that's fluid in the abdomen. And then there's the radio density in the thorax is of varying radio opacities. There's a shape that's almost circumscribed dorsally.
Yes, can you show us that? Okay. So perfect, awesome. Okay, I completely agree that looks abnormal. I like the word that you used there. Well, it seems to be circumscribed. It's a very important call. Are things diffuse, or are things well marginated, well circumscribed? Are they diffuse, are they focal? The list of differentials that we usually get after making that call are different. So that's a very good point. Before we keep on going into that, we left how a fat cat and thin cat looks different. I'll tell you the big point. In a fat animal, basically, the volume of that thorax is going to be reduced, so it cannot expand that thorax that much. So, and then the abdomen, this is probably more in a dog. There's a cranial displacement of the diaphragm. So overall, I'm a lot more tolerant about the increase in the lung opacity. Makes sense? So the lung looks a lot more white in a very fat animal. 2 reasons: a lot more tissues surrounding. So it's not silhouetting. It's not that we are going to be unable to see the vessels. It's that the overall opacity of the lung looks more white. It makes sense. It's like putting more water on top of the grapes, not in between the grapes. And then the reduced volume of that thoracic cavity, also there is less gas. And if there is less gas, there is less black. So there is more white outside, less black inside. The overall appearance of the lung looks like there is a diffuse increase in lung opacity. So if you are dealing with a very fat cat dog, be more tolerant about the overall opacity of the lung. And this is very, 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 very clear. When you have a huge dog, very fat, you take a radiograph, the lung looks very white. You do a CT, and the lung looks completely normal. the wideness of that lung was actually superimposition rather than true lung disease. And this is where radiology gets hard. You know, making that call is very hard. So let's move on and with that. And then let's go into this abnormality. So I agree that there is something up here looking abnormal. I agree that now we are adding stuff. Is soft tissue, is well defined. Can we make a call about where is that located?
So the esophagus.
Okay, and why are you saying that? Can you defend your position?
Just because of the location and because the trachea and the heart look sort of displaced ventrally.
Okay, good point. So, perfect point. So location is in the dorsal thorax. I'm not going in particular into any of those because we need to go back to the other projection and decide if it works. I really like your comment about the displacement. I'm not sure I completely agree, but if it is, then the way that it works is if the trachea and the heart is displaced, then there has to be something either very big in the lung or something within that same compartment to result in displacement of that structure. So I like the thinking. I'm not sure I agree, but I like the thinking. So can we try to locate this abnormality up here in the other projection? Because if we want to, that is a good option, a good hypothesis. The esophagus runs up, actually the esophagus runs more like there, but that's a good hypothesis. But if that is the case, then you should have a very specific location on the other projection. Make sense? So in order for us to decide if that abnormality, actually, if I only give you the lateral projection, this white stuff can be anywhere, can be on the skin, can be on the thoracic wall, can be on the lung, could be on the mediastinal, could be anywhere. So once we find this and we decide that it's abnormal, and I completely agree with that, where is that on the other projection?
Down here.
Okay, good point. So let's go back. So now is increased opacity, is well marginated, is dorsally and caudally, but also left. My sense is, am I convincing you, Helen, that it's probably not esophagus because it's so much to the left? I mean,
Yes.
It goes up to here. Okay, cool. So that was a good thinking, but then anytime we think about the esophagus, then it should be sitting somewhere here. It goes to the left a bit. The cardia here is a bit to the left, but not that much. So there is a lot. And there is another point that kind of came, which is the arrow that I was, or the drawing that I was pointing at this, actually wasn't stopping here. It seemed that abnormality seems to be going all the way. What do you think about that? So now if you just take a look at this projection, and we decide that it's on the left, and we probably, so how much of the left hemithorax is affected? Is it only caudally or is it more cranially as well?
Looks like most of it.
Yeah, I agree. So here is probably not that easy to see, but if we come here, actually this is a very nice lung. It's that's the cranial, the right cranial lung lobe. The right middle lung lobe is going to be somewhere there. The right caudal lung lobe is going to be somewhere here. The accessory is going to be somewhere there. But if we go to the left, I would say other than this bit of gas in here, then the whole left thorax or hemithorax, then we need to make a call. Is that in the pleural space? Is that in the lung? Is that in the wall? We need to discuss about that. But it seems that whatever is in that hemithorax is occupying almost the entire hemithorax. Would you agree with that? So I don't know how we're going to put this together with the vomiting or regurgitation, but at least something looks very abnormal here. And the entire left hemithorax looks more wide. I have a couple of questions, and we are going into difficult territory, okay? So, I'll ask anyway. How can you explain these well-defined contours? Or probably before even going there, what's your feeling? Where is that located? If I give you the three options, pleural space, wall, 4 options, mediastinum, lung, pleural space on the left, or thoracic wall, which one of those 4? And probably here, just go with your gut feeling. It's okay if you can defend your position a lot, but which one of those compartments do you think is affected?
I'm going to put a vote in for mediastinum.
Okay. I'm gonna try to. I'll see if someone wants to challenge you before I do.
I'll go lung because it's moderately well defined. On the VD, I think I can see vascular patterns out on the cat's right side, but the vascular patterns on the lateral extend beyond the gaseous area. So that's a harder call, I think, but it's either free air or it's lung. So I'll go lung.
I'll go lung, diffuse.
Okay. And any more arguments about why you think there is lung? One was the vessels, and yes, we will leave it there. The other one is any other argument why that is lung? It may be a very simple argument, but this is where we bring the features and the very simple list of features. How a mediastinal mass looks like, how a pleural space mass looks like, how lung mass looks like, or mass or disease. And this is where we bring those features and we try to find the best fit. So those that defend that is in the lung, can you tell me why? I go back to the vessels comment, and so if we believe that, I love the argument. So if you say, well, I want to check the lung, you need to check the vessels because they are a marking of the lung. So that I love that you are going that way. So if you're going to use the vessels that are going here, there we need to be a bit careful because the vessels that we see here may not be the vessels on the left lung, maybe the vessels on the right lung that they are superimposed. So one argument for that to be in the lung is, I would put it the other way around. I would say is our inability to see the vessels coming to the left. Is that right? So if we have a disease that is in the mediastinum and is unaffected, then the left lung is unaffected, then the lung could be displaced. But if it's not all atelectatic, then we should be able to see the vessels. Similar thing, but opposite. If the disease is in the pleural space, probably the lung is going to separate from the wall. And now, but always keeping in mind how atelectasis can fool us, then if the disease is not within the lung, we should be able to see the vessels. Our inability to see the vessels is like grapes surrounded by fluid. Make sense? So the inability to see the vessels is a feature of that is within the lung. That's how I would put it. And I'm interested in you, and I suppose is based on the clinics that if the animal is regurgitation, you want to put it in the mediastinum. And it's very hard to, once that is triggered, once we look for something in the mediastinum, to move away. But I'm still interested in, do you want to bring any feature, radiographic feature, that makes you think that that could be in the mediastinum, or in which way the mediastinum could be affected to explain this?
It's so hard to put these like impressions into words. I admire your report writing ability. So the thing that made me think mediastinum was that I felt like I could see kind of silhouette of this opaque structure here and then continuous down here, and to me it looked like a widened caudal mediastinum.
Okay, good point, good point. Excellent.
But then I felt like if that was the case, if the mediastinum was so significantly widened, then this area of lung should have been atelectic and obviously more dense than the lung on the right hand side. So I thought maybe it was actually on the lateral, it's quite dorsal, so maybe the actual majority of lung isn't compressed and that opacity is just in the dorsal caudal mediastinum. But I really clinically want to make this a mediastinal disease. So I'm biased.
Your argument is very good. So I honestly, I don't know what that, we will go in the CT and we will see what that line is. I'm not sure how to explain that line, honestly. But the argument that I would have to counter argue, to put in front of your argument, would be that it's not in the middle. It seems to be a lot to the left, even if you take that line. So somehow there is that widening that I see, but it's a bit asymmetric. That would be an argument. And then I'm going to bring one feature that, I don't know if it was mentioned, but there seems to be, I don't know if it's an air bronchogram, but some kind of a vesicular pattern here, so a little bit of gas. So I want to think that is most likely in the lung, and I will keep the mediastinum thing there because I think your point is a good one. I want to probably rule out the possibility of a severe pleural disease. And the reason that I'm going to do that is because I don't see the separation of the border of the lung. Makes sense? So even if it's very severe, then somehow I want to see that separation of the lung. So I would be happy to conclude here that there may be something in the mediastinum and mostly in the lung. How are you going to put these two things together? How can you end up with something in the mediastinum and something that is affecting the entire, that it has a very unilateral distribution? Makes sense? So the right lung seems to be unaffected. The left lung seems to be extremely affected. How can we, even if we, how can we explain such a distribution of lung changes? Theoretically, even if you don't see it here, what could be happening? So then we have the entire left lung is affected, the right lung is unaffected. What could be happening? And this is the point that I was driving you here, because this is where this is the take-home message. How are we going to think about unilateral distribution, so markedly unilateral? And then the next case is going to be, how do we think about also unilateral distribution, but also lobar distribution? How can we, and probably here I bring this thing that I wanted to ask you, but I'll probably bring it. This sharp delineation is not the sharp delineation between the actual disease and the non-disease. Is the delineation is a lobar delineation, is a border of a lobe. So one lobe, this is going to be the accessory lung lobe, is normal, which is right, and it's in here, and it's against a very abnormal lobe. So this seems to be a disease. And now I'm asking you to guess which type of disease can result in the entire left lung, all the left lung lobes affected and not affecting the right lobes. Which kind of disease? Where is the location? What's the distribution? How should we think about a distribution like this?
Having worked in the Riverina for 5 years, I could go grass seed abscess.
How would that operate? So the grass seed is a foreign body, is in the airway, is in the bronchi, I suppose, and is traveling around the left lung lobe just because of gravity. That would be your thinking.
Yeah, I removed once a piece of Christmas tree from a dog's bronchus, and the whole lung was atelectic.
Yeah,
that's how
I suppose
something made me scope it. That's how I found
if
it.
that foreign body goes and somehow stays, I don't know what's the odds of a foreign body, if it's more likely for a foreign body to, I think once they go in, they stay in, so in the lobe, or if the foreign body is all the way into the bifurcation, and now is affecting all those lobes to the left. So if we think about a foreign body, I think we should put it probably where in the bifurcation here, that is affecting the left.
Yeah, well, the grass seeds, I think, are very antigenic, and they're also associated with a lot of bacterial infection, and they migrate readily.
Mm. Mm. Good. Any other consideration?
I guess a massive aspiration event to the left side, but I'd expect the cat to be really sick and oxygen dependent, etc. with that level of coverage.
I think that's a beautiful comment, because this puts it into context as well. The cat was vomiting, regurgitation, so having aspiration pneumonia is there. And this is an exercise, makes sense? So me bringing a counter argument doesn't mean that you should stay quiet, makes sense? We just play with the argument. So my argument against that would be, there seems to be a very dorsal distribution. So the main thing for an aspiration pneumonia is the ventral distribution, more than the unilateral. So usually is whatever is, if you go in a CT, whatever the bronchi are going more ventrally because of the weight of the aspiration. So it's gonna usually affect the left cranial, the right middle, and the right cranial. And in this case, we have a clear disease that is affecting the left caudal, and nothing is happening on the right. Okay, so again, these are all arguments, and because I know what it is, I probably have an advantage. But this is the exercise, you know. So we put a hypothesis and we keep thinking. So good point, in context, somehow fits, but not completely. Any other argument?
There's a chat message from Julian saying maybe an embolism in the left pulmonary artery.
Very good point. So then now we are getting that. I need to get the chat. Anatomically, if there is something at that level of the bifurcation, it can be a pulmonary thromboembolism, then we can explain that unilateral distribution. It has to be a massive one, and it has to be, but it could happen, that is affecting that left lung. That's perfect comment. Any other?
Slightly off track, there's the trachea in.
Yeah, well,
the head seems to be.
The trachea is not off track, because if the animal was regurgitating, then we are concerned about the esophagus, and the trachea and the esophagus are very good friends. So it's a good point. I think it looks a bit odd. I'm not sure I know how to describe that being odd. There is one thing that we haven't described, which is that line. Do you remember that we talked about that line when we talk about the pneumomediastinum? And then that can also happen if there is gas in the esophagus. Gas. So now we have that gas against that muscle, and then we have kind of the same gas bringing that contrast, but the gas is not free, but rather within the esophagus. Okay, so I'll give you what the book says. So if you go by the book, anything that is lobar or unilateral like that, we need to go up anatomically, and we need to go to the area of the bifurcation. Makes sense? So it is classic the lobar. So if there is one lobe affected, we need to think about either blocking the airway or blocking the vessel. Make sense? Or those are the two, and then that's a way to think about it. And then the other one is something in that pleural space, like a chronic pleuritis, and that's more a restricted process. So it's either the lung, there is something surrounding the lung, that lobe in particular, or there is something in the airway or something in the vessel. That's how we need to think about the lobar distribution or the unilateral distribution. So the considerations about the pulmonary thromboembolism are good. The other one is a foreign body. I would make it more than a foreign body, something obstructing the airway, and something that is on the left, obstructing the airway to the left. If we have something there, probably in the mediastinum, in the tracheal bifurcation, and it obliterates, compresses, obstructs the airway to the left, we can solve the problem. Okay, so I don't see it, but based on the distribution, has to be something in the hilar region, has to be something way up to explain this unilateral distribution in the airway or in the vessels. Okay, that was my read of the case. And I said, well, that is all very good, but I can't see it. I see kind of the consequence of that. If we want to see more, we need to do CT. So we decided to do CT. So I'll probably go to the, let's go to the answer, which is the one with contrast, and then we'll discuss just a little bit about CT and why I decided to go with this contrast. So I'm gonna go slowly. Let me go like that. So this is the left, this is cranial, there's contrast in the vessels, this is the trachea, that's the lung on the right, and I can see vessels. This is esophagus, that is very distended. This is left lung, that looks very different from the right lung. Okay, up to now, hopefully you follow me. That left lung looks very abnormal. That right lung looks very normal. Trachea, esophagus. Big vessels with contrast. Keep going, I'm rolling caudally, okay? So now we follow trachea, that somehow it got narrow. The esophagus, that was gas filled, now it goes into here. We'll try to figure out what is that. Trachea, again, normal, right lung, very abnormal left lung. Aorta, abnormal left lung, normal right lung. Okay. This abnormal left lung goes all the way. This is gonna be the accessory lung, low. Okay, that kind of sits on the midline. Let me go all the way so we have a good idea about everything. So this is right, caudal, nice airway, now nice pulmonary artery, pulmonary vein, accessory, columnar cava, aorta. This is the left caudal lung lobe, very abnormal. This is how it should be, gas filled. This is fluid filled, but we still see vessels inside. Okay, and that goes all the way, and now we are in the abdomen. Okay, I'll come back, and I'll try to use the theory. Do you remember that we said, well, there has to be something at the level of the bifurcation affecting the principal main bronchi to the left. So let's go back. Bronchi or vessels, okay? So if we go back, let's try to, we get into the trachea and we try to see a bifurcation, okay? So now we try to go bronchi by, bronchus by bronchus for each of the lobes. So trachea. Okay, that is to the left cranial. Okay, that it works okay. That is right cranial. Let's see what happens. Gone. Okay? Gone. There's no more airway there. This, I come again, trachea, goes to the right, perfectly fine. And I can follow that. That goes to the right cranial lung lobe. If I go to the left, that one completely obliterated, gone. If I keep going, actually the left caudal is this little guy here. Oh, I'm probably even wrong. Probably that is accessory. The left caudal is not even, doesn't even take off the trachea. Makes sense? So it's completely obliterated. It's not there. It should follow these vessels. And then what we have is a huge mass in the mediastinum that is, it's hard to tell if that is like an extramural mass that is obliterating the airway, or if it's the mass actually originating from the airway. And because it's partially in the mediastinum, it's also obstructing the esophagus. So esophagus is gas filled, and that explains that image that we saw. And then it got completely obliterated, and that explains the clinical signs. So there is to summarize, it's a huge mass in the mediastinum, obliterating the esophagus, but also obliterating all the airways to the left lung lobes, which resulted in atelectasis of the left. So part of this is a mass, part of that is atelectasis. Makes sense? So the mass, the reason why we couldn't see the mass radiographically, it was because it's in the mediastinum, and also because the mass obstructed the airway and resulted in atelectasis. And atelectasis and mass, they silhouette. So we just see the consequence of the mass, and because the mass is in the mediastinum, it's kind of hard to see. Difficult case. The reason why I wanted to bring this case, coming back to the beginning, is I wanted to show you a case with a very severely unilateral distribution, and think aloud about how we're going to think about those situations. And we need an all lobar. So, and we need to think about those as something affecting the airway or the vessels that are feeding that lung or that lobe. And this is a beautiful case. This actually was a bronchogenic carcinoma in a cat. And it was just growing into the airway, so aggressive that it was extending into the mediastinum. And I haven't seen it now, but I remember there was also invading the vessels. So super aggressive neoplasia. Interesting case because, I repeat, because it's obstructing the airway and resulting in the atelectasis, we don't see the classic pulmonary mass. Makes sense? So the classic pulmonary mass is out in a dog, around the mass, well-defined contours. Bronchogenic carcinomas in cats, they are difficult because they grow into the airway and they obstruct the airway. So they almost never have this very nice tennis ball shape. Makes sense? It's basically resulting in atelectasis. You can see nodules, you can see mass, but it's more going into the airway. So I thought it was an interesting case to show you the result of an obstruction of the main bronchi to the left, and how that results in atelectasis on one side, and to trigger the thinking or the differentials if we have something with a very unilateral distribution or a very lobar distribution. If you go to the book, it's going to say there has to be something at the level of the bifurcation, there has to be something either at the airway or in the vessels. Before we move on, do you have any questions? I understand this is a difficult case. So this may be one that benefits from going back and going in detail. I think this is a very nice teaching case where even if you feel upset or you haven't got everything about the case, I hope it triggered your interest to go and review it and review the features and the principles. I want to
Can I ask a slightly unrelated question?
Yeah.
Well, it's related, but not directly. With megaesophagus on X-rays and CT, obviously with general anaesthetic, you can get a megaesophagus anyway. How much kind of tolerance do you give to it just being general anaesthetic related rather than actual pathology? Like the megaesophagus on this cat, could that be anaesthetic related or not?
Oh, I give a lot of tolerance because I think that's a very functional thing. So once you put them under anesthesia, then then there's no way you can know.
Okay.
That in general. However, let me show you something. In this case, I'm convinced that is not the case. And the reason why I know that is because I see the mechanical obstruction. So that is going to be the esophagus here. And then the mass, so this is a sagittal reconstruction. And then this is the mass, which is sitting in the mediastinum and is obliterating all the airways. And it's completely obstructing the esophagus. So the esophagus goes up to here, and then I can't follow it anymore. So the mass is so big, and it's sitting in the mediastinum, that is compressing the esophagus. So in this case, and then the caudal esophagus is unaffected. So this is a classic case where there may be some functional thing going on because of anesthesia, but in this particular case, I would consider that irrelevant. Makes sense because I can see a clear mechanical obstruction. So this is another view. This is probably a very nice view. So let me go up and down. So that's the trachea. You see the airway going nicely to the right, and now try to see the airway going to the left. We will see that it's gone. Makes sense? So if you follow that, it's going to be obliterated. It's going to be gone. Makes sense? And nothing going to here. So the mass is sitting here, obstructing everything that is going to the left and the esophagus.
Okay, so in the absence of any obvious other stuff, you can't rule out a general anaesthetic causing it, basically.
I agree with that statement.
Yeah. Okay, cool. Thank you.
So if I'm concerned, so when is that I would use CT for esophagus? I will use CT for esophagus if I'm concerned about a morphological thing. Makes sense? So
yeah.
If I think, like in this case, there may be a mass outside the esophagus or inside the esophagus, or if there is a vascular ring anomaly, or if there is a spirocerca or whatever, granuloma, or if I think there is a mass, or if I need to decide, is this mass in the esophagus or outside in the lung? Makes sense? Is it in the accessory lung lobe or is it in the esophagus? Radiographically, they are very, very close, hard to decide. I would use CT for those reasons.
Yeah.
I would never use CT for functional. Makes sense? I would never use CT to say, is that esophagus working okay? For that, I will have the dog alive, not under anesthesia, of course, alive. And I would challenge that esophagus. Makes sense? I would give food and contrast, and ideally I would do fluoroscopy.
Yeah. Okay. Cool. Thank
Mariano, you. The mass is not vascularized. It's not lighting up.
Okay.
Contrast. So is it just the phase of vascularization that's caused that, or is there some other reason?
Probably not as much. And I show you there the very early. I have a later. So what we are doing is we are giving time for that mass to uptake some contrast. And this is later, and you can see very nicely the difference between mass and atelectatic lung. It's beautiful. So this is a mass, is heterogeneous, is amorphous, let's say, or rounded. This has the airway inside. So this is the mass, this is the atelectasis. For a radiograph, it's very hard for CT. And then it's easy. The mass is extending along the airway, going to the left caudal lung lobe. And I know that because I can follow the vessels. And now on the left, there is a mass surrounded by atelectasis or bleeding within the lung. And this is the reason why we couldn't see the contours of that mass. Coming back to if it enhances or not, there seems to be patchy enhancement. So, and for that, what we need to do is come here and then open, so let's open the pre and post. So we find, let's say, that area, that is abnormal, is in exactly the same place. So what I can do is to have a more objective measurement. So that measures 131, probably I'm here in the same area, and that measures 57. So it is enhancing. So that part is enhancing. I would, regardless, I will not use the enhancement to predict what type of mass it is. Sometimes very aggressive masses, they don't enhance because they are so necrotic. And that will not keep me from calling them masses and very aggressive. If I would just, it helps, contrast here helps delineate. Look, let's go back here. So there is no contrast. If I give you this CT without contrast, it will be very hard. So it will be useful to see the airway because it has the natural contrast in the gas, with the gas, but it would be very hard to design. I would see that obliteration of the airway, but it would be very hard to learn about the vessels in here or separate what is mass from what is atelectasis somehow. Contrast gives us all of that information. I would probably not use that to predict what the nature of that disease. There is one other very interesting thing, which is, and I love it because it's counterintuitive and it's kind of breaking the rule. The classic masses in the lung, you know, the classic image that comes to mind when we talk about the lung mass is something rounded, soft tissue, well defined. And if anything, it's going to be increasing the volume of that lung. This mass is acting exactly the opposite to anything that we know, that I mentioned. This mass is resulting on a reduced, not increased, reduced lung opacity and lung volume. This is the right lung and is larger, and the left lung is smaller, even though it has a mass inside. Why? Because it's obstructing the airway. This mass, the classic mass, results in a soft tissue, well-defined mass. This mass is not well-defined. Why? Because the surrounded lung is soft tissue. Why? Because of that atelectasis and probably bleeding within that lung. Makes sense? So the bronchogenic carcinomas are almost breaking, like cats, you know, they break all the rules. They look extremely different from the classic single pulmonary mass, classic in the caudal lung lobe in a dog. Okay, complex case. I hope you enjoy navigating through the complexity. And if there are question marks, I'm extremely happy because we can keep on going through them over the week or next week. But I hope it triggers at least the interest, or you find this case interesting. I love those radiographs. There's so much information in those radiographs that if you go through them very fast, you just miss half of it. There are many small details that they all make sense, and the CT can explain all of that. And I have the confirmation in this one. It was bronchogenic carcinoma. It was very easy to sample because you just put a probe in here and then you put a needle in there, and it was very, very easy. Again, because the lung disease extended all the way to the wall. Okay, so this acts like a good introduction for the next case, which I suppose we leave it for the next time because we have only 10 minutes. There are some similarities to this case, and I think what we discuss in this case is going to help us approach the other case and have a kind of a little mental scheme, you know, how we're going to deal with these situations of lobar distribution or unilateral distribution, how we need to think about it. Okay, I will post this CT on the forum. And again, so if you have the time and you enjoy imaging, I highly recommend you go and go slowly back and forth, and then compare the image, the radiographs with the CT. The CT in this case is going to help you understand the distribution of the disease and the mechanism of disease. And you don't need to be, you take advantage of that. You don't need to be an expert in reading CTs. CT is helping you understand that disease because it provides a lot more information.
Mariano, I looked for the instructions for joining the forum to send out again, and I just couldn't find them in my files.
So let me go now and share an invitation link.
Share what, sorry? An invitation?
Like an invitation link.
That would be great.
Home, manage, members, invite, copy. Good. Chat.
Now, if I send that out in the emails, that will work, yeah?
I think so, yeah.
Great, okay, I'll do that right now.
Okay, so I think we stop here, unless there are questions. I insist, complicated case, these are the learning cases, because sometimes if they are too complicated and we don't know the answer, then we are left with, well, we don't know. This one we know what happened. So interesting to revisit, go through the images again. If there is something in that, in our thinking today, we made plenty of statements, and we logically, I hope, advance in our knowledge to the case. If there is something in that chain that you feel unhappy with, or you couldn't get how we went from one finding to the conclusion, please bring it back. Makes sense? Because this is exactly what we need to learn, is the finding, how we think about the finding, and how we move on. And that principle, that's a principle that is going to be useful not only for this case, but from any other case. So it's important that you revisit those principles, those things that we said, and if there are questions, then we can revisit. I hope we are going to revisit some of them with the next case, because they are similar but different, and that's why they are very interesting, and that's why I put them together.
Just a quick question, Mariano. Would you have seen that mass on ultrasound with the collapsed lung next to it, or would it be too deep?
Okay, so actually, I have the ultrasound, and we did it before the CT. Let's look. And I think we could clearly see a mass. We were unsure the extension and how many structures were involved. And I think we were unsure. I remember my point was, this is something affecting, because of the regurgitation, there has to be something in the mediastinum. And there's something obstructing the airway or the vessels to the whole left. Yeah. But I couldn't decide where is it coming from. Is it from the esophagus? Is it from the airway? Is it from a lymph node? Is it from the lung? I knew that those two compartments were affected, but I couldn't go further. And I don't think we tried, but I don't think, I'm just looking that it was mostly abdomen. Yeah, it was mostly abdomen. I'm sure I put a probe and tried to figure that out. And I would say that it would be very hard to get that. It would be very simple to sample, but probably very hard to get that very nice picture about what is happening with ultrasound.
Yeah.
Okay.
All right.
Thank you very much.
Thank you.
Thank you, Mariano.
Yes, thank you, Mariano. That's brilliant as usual.
Thank you.
Thank you. Have a good week. See you next week.
You too. I'll see you Thursday.